Okay, let's get started with this evening's Miami Global Brain Tumor Symposium. Welcome, everybody. This is our 25th session. We started since COVID. And quick introductions before we start with tonight's speakers. My name is Michael Ivan. I'm one of the brain tumor neurosurgeons here at the University of Miami, specializing in brain tumor and skull base, and director of our research program. I'm joined tonight by my co-directors, Dr. Morcos, professor and co-chairman of our department, and also director of cerebrovascular and skull base. Dr. Komatar is professor and program director of our residency, also director of the MBTI and surgical neuro-oncology, and Dr. Benjamin, assistant professor here at the University of Miami and director of our skull base lab, which is called the Keynes Lab. Each week we put on these sessions and share them with everybody, and we couldn't do it without the great help of all of our administrators, both from the support of Sylvester Cancer Center, University of Miami, and the neurosurgery department. So thank you all. If anybody wants to learn more about our department or about our symposiums, you could always find us on social media or on the web. We're active on Twitter, YouTube, Instagram, as well as the website, which you could see here. So please be free to check out those for upcoming talks. And speaking about upcoming talks, every Thursday, we also put on a cerebrovascular and skull base symposium, and tomorrow night is no exception. Dr. Morcos has put together really an exceptional panel talking about neuroanatomy in the brain with panelists from all over the world joining us. So please be sure to join in tomorrow night, same time for that expedition. Next week, we'll be also having our Wednesday Miami Global Brain Tumor Symposium. We have the pleasure of welcoming Dr. Luthart from WashU, joining us to talk about LIT and how their experience at Washington University has been thus far. Quick housekeeping. So participants, please, we try to make this as interactive as possible. Use the Q&A button. We don't offer CME, but you will get email participation, and please be sure to like, follow, and share our videos so we continue to share them. So let me get to tonight's panelists. We're welcomed by really an exceptional group of pediatric neurosurgeons and neuro-oncologists from around the country. And I want to thank them so much for taking the time to join us today. Michelle Maggi is joining us from Stanford. She's Associate Professor of Neurology, also with joint appointments in neurosurgery, pathology, psychiatric, and pediatrics. She's a medicine faculty scholar at Stanford and also is the PI for very, very successful brain tumor laboratory. We have Dr. Storm as Chief of Neurosurgery, co-director and Center for Data-Driven Discovery in Biomedicine, and a brain tumor specialist. He's Associate Professor of Neurosurgery at CHOP in Philadelphia. Dr. Hankerson, who's a professor of neurosurgery and a brain tumor specialist in Denver, and is a part of the Children's Hospital of Colorado at their medical campus. And Dr. Niazi, who's a medical director and neurosurgical oncologist here at University of Miami. She practices at both Nicholas Children's Hospital and Jackson Memorial Hospital as well. Tonight, we have a very special keynote speaker joining us from New York, Dr. Mark Swedane, who is the Vice Chairman of the Department of Neurosurgery and Professor in the Department of Neurosurgery and Pediatrics at Weill Cornell. He's also Director of their Pediatric Neurosurgery Program, as well as the Director of Memorial Sloan Kettering. He's really an exceptional and well-known neurosurgeon, especially for his research on DIPG, and which is why I'm so happy that he's able to join us to talk about this talk. We've had many people over the last 25 weeks kind of ask us to talk about this. He's also has an international reputation for removing intraventricular tumors, management of pineal tumors, congenital cysts, and Chiari. And he really leads the way on endoscopic surgery, especially in pediatrics. And both himself and Dr. Schwartz lead a phenomenal workshop every year at Cornell, working and looking at endoscopic neurosurgery. So for those of you interested, you should definitely check it out. He leads a very active clinical practice. He has many publications I'm not going to go into, and he also oversees a transitional laboratory which focuses on treating incurable brain tumors in children. Of those, he really leads the way in development of some novel drug delivery techniques for unresectable brain tumors, which I think he's going to talk to us about tonight. So I just want to thank him so much for taking the time out of his busy schedule to join us tonight and talk to us about such a difficult topic as this. There you go.
First thing, Michael, very kind invite. I thank you and everybody at the Department of Neurosurgery in Miami. I probably wouldn't have accepted the invite had I known the list of panelists, to keep me honest. I probably would have declined on your kind offer, but you're pitting me up against some unbelievably talented individuals that deal in this disease. I never would have thought I'd be given a concentrated talk to neurosurgeons on DIPG as a resident in training who had a passion for taking out craniopharyngiomas and working around the third ventricle, and Mike Capozzo's book being my Bible. I never thought I'd be talking about catheter-directed, chemotherapy into the middle of the brain, through a twist drill. But here we are. Your careers take odd trajectories. So I labeled this "No Longer False Hope." That might be my own bias moving into a realm that I shouldn't have moved into 20 years ago. But it's continuing to fuel my investigative approach toward these and similar types of tumors for which we have no good alternative. And hopefully by the end of the talk, as well as maybe the comments by Michelle and Jay and others, we can provide some element of progress that we're making in this disease. From the standpoint of the neurosurgical armamentarium and, a call to arms, this is the passion for all of us as neurosurgeons as it relates to cytoreductive surgery. That's really one of the drives for me going into pediatric neurosurgery, the deep-seated tumors, the passion for taking these out in an elegant fashion. And across the board, regardless of the tumor substrate, there's very well supported cooperative group information justifying the role for aggressive cytoreductive surgery, medullo back, when I started my residency, being front and center in the need for extent of removal to be within a certain threshold to improve the prognostic outcome of these kids. Low-grade gliomas, similarly, through multiple cooperative group efforts, whether they be infratentorial or supratentorial. You see that difference in outcome dependent on extent of resection. These are all pediatric series and pediatric cooperative groups. And most notably in ependymoma, a real challenge for us from the standpoint of the infratentorial ependymoma in children, having a widely disparate outcome in EFS depending on extent of removal. And that is the mindset of the pediatric neurosurgeon going into the domain of focusing their career in oncology. As you shift into the brainstem, and I remember during my residency and these papers starting to come out talking about the differences between brainstem tumors, Leland Albright, Fred Epstein, and other notable individuals in our field using MR to start to draw a histopathologic correlate to the disease we were looking at, and whether or not there would or would not be a role for surgery. Some of those being depicted here on the right. The classic categories of these, the dorsally exophytic tumors, the focal tumors, the cervicomedullary tumors, and of course the DIPG. Some include the tectal tumors. Nevertheless, using imaging as a predictive aspect of whether or not there's a surgical or even oncologic interface and what that correlative histopathology is. And that really lays the groundwork for a lot of our mindset when we see these kids present with whatever clinical symptoms they are presenting with. That also, depending on that difference in outcome, lays the groundwork for this idea of just this surgical abandonment, or this mindset that the DIPG has no role in the neurosurgical infrastructure. And this predates all of our lives, and certainly as old as neurosurgery is. And Harvey Cushing's quote you can see there from over 100 years ago, that this is off domains. This is a domain that the neurosurgeon shouldn't be interfacing with for obvious reasons. Of course, without the infrastructure of imaging and understanding the differences in types of masses in the brainstem influence that. But nevertheless, cautionary notes along the way. And in more contemporary times, Donald Mattson in Boston really emphasized this idea that gliomas, and specifically certain types of gliomas, really are inoperable lesions. Inoperable being a very junkyard term from the standpoint of interface. And that's been kind of the fulcrum for revisiting this idea of the neurosurgeon's interface as it relates to DIPG. There have been over certainly my career and over the past 15 years plus a reassessment as to whether or not we should be interplaying in this, and really driven by excellent scientists. And Michelle's very good to this, Cynthia Hawkins, from the standpoint of needing tissue to make some decisions about how to treat these kids was really one of the big impetus behind revisiting this idea of biopsy. The idea of biopsy wasn't new, in the 1990s, late 1990s. The technique has been well established by a lot of our predecessors, but the idea about doing this and for what purpose became a lightning rod in pediatric neuro-oncology. So that was one, and then obviously in my own career trajectory into the idea of drug delivery was another. But as you watch this evolve in this particular disease, the surgeon's interface becomes a crucial component of it, and I think most would agree as we start to look at other novel therapeutic approaches. It doesn't, I don't think it's a surprise to anybody, but the traditional approach toward doing this is external beam radiation therapy. And in this radiation oncology plan, it emphasizes the regional, and I'll stress that regional approach toward this disease, which is really unique amongst pediatric neuro-oncology. It's pretty rare we treat other than low-grade tumors, but anything with a malignant phenotype is rarely ever treated with localized treatment paradigms. DIPG certainly has been treated this way since I ever heard about the disease, and is still considered to be the standard of care, and if there is such a thing as standard of care in this disease, in all walks. And it's between 59 or 54 and 59 gray of radiation therapy. Obviously, the normal history of that is 60-70% of these tumors will respond dramatically. Clinically, radiographically, it's not a durable response, and when measured in months, you're going to see some recurrence of disease. And then beyond that, measured in weeks, it's usually invariably a fatal fate for the child, with a median survival that hovers usually less than 12 months. Whatever cooperative group study one looks at, whether it be in North America or Europe, and this is one representative result from the PBTC overlaid on some historical data from the Children's Cancer Group, 9941. And that curve, that really poor prognostic curve in this disease would predict that by 1 year of age, nearly 3/4 of these kids, if not more, have passed from that disease. And rarely do we ever get somebody beyond that 2-year mark. And this is really duplicated with every large-scale cooperative group, really as far as anyone can imagine. So external beam radiation therapy, continued observation, clinical trials has been the platform for treating this disease. One of the things that have gravitated me toward this is, if you think about this relative to other pediatric brain tumors, I mentioned medullo, which we, depending on the molecular subtype, can cure these at an 80% proficiency, a highly malignant tumor. Germinoma, highly malignant tumor with 90% efficiency with radiation plus chemo. Why not glioma? Why not DIPG in particular? Partly based on the radiographic behavior of this, non-enhancing tumor, infiltrative, maybe intact blood-brain barrier, provides this idea that we're not getting drugs, whether they be effective or not is a whole other issue, but not getting drugs effectively into our target tissue. And that's demonstrated in this plot by some of the work that Kathy Warren has done with some of the primate colonies she's worked with, and looking at different chemotherapeutic agents, penetrance, not just in the CSF, but in cerebral cortex, deep white matter, and specific pons. And you can see this huge disparity between the fractional extraction of drugs in the plasma versus where we want it ultimately in the target tissue. And this is nearly logarithmic in scale. So in that differential between what is available in plasma and what gets into the brain tissue itself, one can easily kind of leverage that by giving higher and higher doses. And that's been the building block, certainly when I started in neuro-oncology, of getting higher doses of chemotherapy into our target tissue. And certainly it wasn't that long ago that we would see significant morbidity from high-dose chemotherapy. So dose escalation in an attempt to get a higher fraction of drug into our target tissue had its negative byproducts. Toxic mortality as high as 10% in some of these. So this idea that you just myeloablate, spill the entire systemic circulation with chemotherapy, and then basically convalesce the bone marrow with autologous stem cell rescue still serves as a building block in high-risk malignancies in the brain in children. So poor penetrance, high systemic toxicity was kind of the push behind looking at different or alternative forms of drug delivery to these tumors. You're very well acquainted with the idea of using biodegradable polymers and conjugated with whatever chemotherapeutic agent, relying on the principle of diffusion, convection. Ed Oldfield championed that certainly back in the 1990s. This idea about getting deeper and deeper into the brain through convective forces with low pressure, constant flows was real based on preclinical work. It was very appealing to me, given that the disease of the blood of the pontine tumors being a target. This cartoon illustrates just the principle of CED, this being tumor, this being your capillary monoclonal antibodies, not getting outside the capillary in the brain, bypassing with some micro infusion, cannula, or catheter to provide whatever drug into the interstitium in a much more efficient way, not just providing drug into the interstitium, but avoiding the systemic circulation. And obviously this is simplified dramatically, but whatever therapeutic agent is in the capillary to some degree is going to be dependent on many features. But the interesting interplay of neuro-oncology as we're watching this evolve is depicted in these types of molecular platforms for therapeutics. Monoclonal antibodies, large protein products, viral mediated therapy with either intact RNA or DNA viruses, liposomal structures carrying a payload of chemotherapy, and cell-based approaches. While these are extremely appealing and usually are invigorating in the preclinical world in neuro-oncology, it's not an absolute, but getting them to our target tissue is a big problem. Notwithstanding the issues I talked about before with even just conventional chemotherapy. So as you start to roll into these ideas of investigative therapeutic compounds that are macromolecular in scale, delivery will consistently be an issue. David Sandberg, who was at Miami for a while, a graduate of our program, was silly enough to jump on this idea and work in the lab for 2 years with me when he was a resident here, about the feasibility of applying direct drug delivery in the brainstem. And credit to him for pushing this forward and taking this into a domain that was at least something that was tangible and reachable. A lot, obviously, between that and our first patient ever put on a clinical trial utilizing direct drug delivery. That's 2012, I think it was. So a fairly large interval of a lot of work that goes into this. And I'm not going to detail all that unless there's questions relating to it. But I do want to highlight the interface of doing this in a clinical domain. A lot of credit should go to Russell Lonzer and some of his colleagues at Oldfield, who I mentioned, Kathy Warren, about once this looked to be feasible in the preclinical sense of actually having the wherewithal to do this. I'm going to talk a little bit about the surgical interface and brainstem glioma, but nevertheless, there were a sampling of anecdotal case reports that quickly followed in that 5-year time period, really talking about and demonstrating that the feasibility of doing this in children for whatever the disease process might be. So while this was happening, what one would take from this, and when I was investing in the preclinical backdrop, was can you do this in a way that is rational? Unfortunately, all of these anecdotal papers would have a different drug infused, different rate, different interface, different navigational platform, different catheter, different volumes of infusion, and the list goes on and on. So one would take from this no meaningful information that would give you a sense of safety. So what I sought out to do then was to really systematically look at this as a phase 1 feasibility study with respect to the mechanics of volumes of infusion and dose of agent. And it was a very simple design, and that was a single infusion of the drug that I'll get to in a moment for kids who are not progressing after standard external beam radiation therapy. And then a lot of imaging to look at response and dosimetry. Just a point to make before we get into some of that is, the drug itself, we kind of cross-referenced and capitalized on a molecule that was being used routinely for CNS relapse neuroblastoma. Then it was 8H9. Now it's commercialized as omburtamab by Y-mAbs Therapeutics, which targets the B7H3 transmembrane receptor, which has some implications in a checkpoint blockade. But the beauty of it that I didn't appreciate at the time was this idea that it was tagged to a radionuclide. So we could actually image this in real time or delayed fashion to look at dosimetry and distribution, which I wouldn't, when we designed the trial, even thought how important that might be. So it made this quite easy to cross-reference it from the standpoint of regulatory, since we are already given this in the intrathecal compartment. So just a couple words about the drug. The workflow, everybody's fairly familiar with approaching the brainstem. There's obviously many different ways of doing this. I'll just say as a disclosure, for almost all biopsies, unless they're diencephalic or rostral mesencephalic, I use a posterior transcerebellar approach. We've always used a supratentorial approach for infusion. Not all do, and I'll get to that in a moment. But certainly in our hands, it's worked well, principally because of the MR guidance system that I still prefer to use in this situation. So all these are done in an MR interface. They've moved out of the OR environment. Now we're in the interventional environment. This can be done in a diagnostic environment, but I still stress the importance, although it's not exclusive, of doing this with MR guidance. So that catheter deployment, I can check at whatever frequency I want on a millimeter scale, if so be it. There's a whole evolutionary talk on what catheters and how best to use these for drug infusion that we don't have to debate today. This is all done at the bedside now. We don't do this any longer in the OR. And when there were short infusions, X number of hours, we would keep them in the MR and do real-time MR imaging. And these are now exceeding 14 to 16 hours per dose. So they're in the ICU, hooked up to a microinfusion cannula. And as I mentioned before, the beauty is getting PET images of drug right within the domain that we want, and getting pretty good distributive maps with coupled with dosimetry of radioisotope. There's a lot of imaging and analytics that go into that. Really, the emphasis behind that first phase 1 study was, can we define either a dose-limiting toxicity based on volume or isotope? The answer was no, and we're still, I'll say, in mid-stride of that phase 1 study, far beyond what we reported back in 2018. The real, I think, emphasis here, however, was the safety, that we could do this repeatedly, and we're well over 40 patients, and obviously we've been finessing it along the way. But the fact that you can get drug and distribution in these kids with space-occupying masses in the brainstem was, and still remains, really revealing under certain parameters. And the other big take-home was the fact that we can now invert that normal fractional extraction of drug out of the plasma into the CNS and flip it over on its head. So we're getting 1,000-fold higher, based on very reliable dosimetry and PET imaging, into our target tissue relative to really anywhere else in the body. So this dual benefit of high concentration and no systemic exposure opens up an amazingly powerful tool when coupled with the right drug and done in the right way. And I'll get into that in a moment. The other is, we've been doing this in a very iterative, way too slow, in my opinion, approach just to maintain safety. But this is now outdated. But in the doses we're giving, in the volumes we're giving now, which is approaching 10 milliliters a dose, we're seeing well over 20 cubic centimeters of coverage fairly consistently. And by most measures, DIPG post-radiation therapy is going to hover somewhere between the 12 and 14 and well over 20 cubic centimeters, depending on the patient. But we're getting very representative volumes of distribution. I was most floored by watching these kids come through this. This is 7 days post-op. It's our first patient ever treated. I'm not a functional neurosurgeon. I had a lot of apprehension about doing what we were doing. Then infusing whatever volume or dose here 7 days later was really captivating to me, to push forward with the conceptual backbone of this. That's our first dose level. Second dose level, this is post-op day, I think it's 6 or 7, and he's going for his PET image. Dramatic, from the standpoint of tolerance. This is next day after dose level 3. The fact that this could be done, and I've done plenty of biopsies, and I really have a passion for operating on the brainstem. It's really hard to get out unscathed in a lot of these patients with regard to subtle cranial nerve deficits. But so to see that type of a response consistently was quite dramatic. The intolerance we're seeing is really governed by volume. And as we get into bigger and bigger volumes and sicker kids, that's the interplay that we have to address in a different way. I wish I could beat my chest and claim we're making a difference. But if you look at these types of plots, we're not. That's said simply. But the one thing we can say is we're certainly not hurting them. We're certainly not taking away an interval of time that's important to them, and not taking them out of the sphere of other clinical trials. This is now a year outdated, but we're well above that now. But our whole cohort in a phase 1 study, which is really hard to extract meaningful information, we're certainly doing better than expected. Is it patient selection? Possibly. Patients that are sick enough not to go on, but nevertheless, we're clearly making strides with regard to the safety and the dosimetry. The thing that captivates me from the standpoint of furthering this, rather than giving up after 6 or 7 years and not seeing a 10% EFS or overall survival at 2 years, are these types of images. And it's hard for me to move away from the conceptual backbone of this and seeing anecdotal cases like this. I just don't recall patients that we see in our multidisciplinary tumor board who are X number of years out without a pons that is engulfed with tumor. So the durable, if you measure this in X number of years, and the anecdotal side of that was impressive. Similarly here, she's now just shy of about 8 years. From the standpoint of, and you'll still see footprints if you look on FLAIR and T2 in some of these, but why is the big question. I think equally captivating to me is, very typical DIPG. This was biopsy proven. She got treated twice. These are longitudinal from time of diagnosis in 2015. About a year later, this is a year later than that, she started to have this very enriched FLAIR-related signal in the cerebellum. That subsided, inflammatory, pseudoprogression, not sure. Tumor progression in the thalami, got re-irradiated. And just watching this outside of the treatment field progression was impressive. Not unfamiliar in the world of DMGs, of having lots of infiltrative capacity within the parenchymal compartment, the spinal cord, the supratentorial compartment. This is the same kid then, nearly 3.5 years out with metastatic disease, biopsy proven in the spine. She eventually succumbed about 6 or 7 months ago, maybe 5 months ago. Nearly 4 years survival, but with a brainstem that doesn't look as if it's got rampant engulfing tumor. So this idea about regional control, are we making an impact? I think anecdotally, yes, even though we might not be seeing a little change in that needle on OS. So it begs a very important question, is can we start to parse out why? Looking at a simple dose response curve, with 3 patients on each dose level, with the numbers we're dealing with, it's not going to work. And certainly what I have seen is it's impossible to pull out of this any meaningful information as to why some patients versus others. But what we've been focusing on more lately is not just dose level, not just OS, but can we start to look at these variables with regard to real good analytics and dosimetry and distribution to now start to stratify our outcomes, since everything is so variable given the nature of a phase 1 study and the patients who come to us. And you get a little snippet of that variability there. So I won't go into a lot of detail here, but I start to put on my radiation oncology mindset here with regard to encompassing tumor dose that we're administering to certain part of the tumor. And what these are, is anybody who's worked with iPlan Flow and the Brain Lab software program, really delineating tumor margin, building this in 3 dimensions. This is pre-infusion, post-infusion. This is not gadolinium, it's just altered T2 signal. Not hard in some of these patients to delineate distribution patterns. So, and trying to come up with an intersect between tumor that's actually been enveloped by infusate, i.e. drug. So a lot of variability. And this is just one example of, based on an estimation, I'll stress. And I know all the shortcomings of trying to estimate tumor volume in this disease, but it's the best we got right now, short of a biological marker. To try and now look at these types of variables, including dose, as a variable and outcome, and that's what we're attempting to do. And as we forge forward in our phase 2 study that we're designing, we're going to do just that. And that these patients will be treated roughly in the same time frame. They'll be stratified based on tumor volume. That'll be dose adjusted and volume adjusted. It will be open for retreatment. We've done this now 7 times. Safety issue has not been an issue. Peter Morgenstern, one of our former residents who's now at Sinai, just published that result. But I think really importantly, we're trying to get our arms around something that is a little bit more of a microcosm of response. And this idea of looking at overall survival when we don't know if we have the right dose, the right drug, the right combination of drugs, the right distribution is frustrating. But if we had a biological marker, a biomarker of response, be it whatever percentage over a short period of time after experimental intervention, it would be a huge coup for us as far as tailoring this as we move forward, making decisions, very expensive and time-consuming decisions about drugs. So we're partnering with our group at Memorial now to do this as our phase 2 study, looking at longitudinal cell-free DNA, which has been done through PNOC. Michelle's very familiar with that. And of course, the playing field is expanding, and individuals are doing this with different agents and different interfaces with variable results as it relates to tolerance, distribution. But as we move forward with different agents, in this particular case, IL-13, which has been used in the supratentorial compartment in adults, one option. PNOC 15, utilizing MTX-110, which is a formulation of panobinostat, which I'll mention in passing. Nalan Gupta, Sabine Mueller, I believe finished that phase 1 component of that study, not yet published. But nevertheless, another drug, another type of interface, different approach from the standpoint of catheter trajectories, number of catheters, et cetera. The group in Spain, I admire, they're doing really good work utilizing a oncolytic virus. This is their schema there. So they're doing pre-treatment biopsy as well as stereotactic injection of the Delta RGD virus. Different catheter interface, again, dosimetry utilizing a form of gadolinium that precedes. This is a dual chamber catheter that allows one to do that. I'm showing this, which is sent by Dr. Alonso. We're doing the same with MR tractography, and it's very clear that predictive modeling, which is going to be part of our phase 2 study, it becomes extremely important. These are descending corticofugal fibers. Proximity to that is uncertain, but certainly infusion into these really alters any spherical type of distribution, and it's not the type of response, not the type of distribution pattern we'd want. These are becoming very intricate. We're in the process of writing guidelines right now in the brainstem as it relates to certain structures and best place of catheter placement. Again, industries following suit to some degree. Multi-port systems, you might be familiar with the Renishaw system. It's UK based. The group in the UK has been using this fairly consistently, using a carboplatin alkylating agent with multi-port systems to encompass more of the tumor. The beauty of it that I like is it's reusable, so it doesn't take another surgical interface. Again, using these loaded payloads is an open clinical trial spearheaded out at SF right now with CED. I know that Jeff Bruce up at Columbia has now treated their second patient using a implantable pump, the ITP pump, hooked up to a catheter to infuse over serial infusions using, again, MTX-110, an aqueous formulation for panobinostat. And then I'll say that there are other devices and interfaces that are attracting some attention with regional therapy, and this is really more addressing a neurosurgery kind of interface. You know, this has been around for a long time, and Ed Newell, who has championed this, has done a remarkable job looking at the feasibility of this. You know, and now trying to use super selective with temporary balloon occlusion and the basilar. It's a huge undertaking, you know, technically, and our interventionalists are so good now that they can do this. The question is, better, worse, additive, you know, time will tell, but there's, insofar as I know, 2 open clinical trials utilizing this for kids with that disease. Very, very interesting, I think, on the horizon, you know, and I think it's just a matter of time. And I don't know of any open clinical trial yet. I know that the group in Toronto has been actively pursuing this on the preclinical side to use focused ultrasound as a means of breaking down the blood-brain barrier or temporarily altering the blood-brain barrier, treating with whatever agent. This is done with doxorubicin. You can see the dramatic difference with focused ultrasound and microbubbles compared with not getting doxorubicin in your target tissue. You know, questions that have to do with the domain, the volume, you know, the children versus adults. These are legitimate, but nevertheless, it's very, very interesting. A couple of things I'll say in closing, you know, and really credit to Michelle and our colleagues on the science side of this. It's just really been dramatic. You know, and my eyes are wide open from the standpoint of, you know, interface, but a lot of emphasis. And for those of us who started our career, you know, when those papers were being published, as far as stratifying brainstem tumors into different categories, this has blown it wide open from the standpoint of understanding. And it's only just a matter of time before, and I think it's real time right now, that certain therapeutic agents are being looked at that have a real biological and tumor-specific basis for being used. Everybody's very familiar with the HDAC inhibitors, the H3K27 mutant phenotype. Michelle has really done a tremendous job of looking at biological mechanisms for attacking this, either in its cellular phenotype or its physiologic phenotype. CAR T cells, I talked about cell-based therapy. Again, another clinical trial using the GD2 receptor with CAR T cells. You know, these are rampant now with regard to the science that's pushing this, and it's really just a matter of time before we start to merge with regard to the couple and the drug delivery route. You know, if this can be done systemically, fantastic. You know, there's no question. But we stand poised and really, really well positioned to partner with whatever comes out of the early phase clinical trials. You know, a lot of investment in the agent itself. You know, a couple examples that I've mentioned already: panobinostat, OCT201, GD2 CAR-specific T cells. Are they going to get there? Are we going to know a little bit more about the systemic toxicity profile? And, you know, like I said, we're fully engaged and ready to use the tools we've developed to address this if it is a concern from the standpoint of systemic toxicity or local delivery. So I'll say that as neurosurgeons come to the table and continue with this interface, just to be smart, to be really, really smart and make sure we're getting something out of these really large-scale trials, not scale as far as numbers, but scale as far as time, money, and effort. This is not easy in any way. But, you know, like I said, this has been very painfully iterative, but there's nothing more that I think about every day as we either treat a child or design a trial that I don't emphasize the issue of safety first and foremost. If we're not monitoring dosimetry, whatever means, be it radio labeled or otherwise. We're missing a great opportunity from the standpoint of response monitoring, and then finding earlier and earlier markers to guide us from the standpoint of correct dosimetry, frequency of administration, what frequency of administration. That's going to be a painfully slow, if not even accomplished goal, unless we have some type of biomarker that gives us a signal to move forward or to pause in certain dimensions. So with that, I'm going to stop that component of my talk. Michael, I don't know if you want to take questions now, if you want the panelists to weigh in, but thank you very much again for the invite and the opportunity to talk about this.
Yeah, thank you so much. That was fantastic, and congratulations again on the work. It really is a challenging disease, and it's finally seeing some progress is so encouraging. You know, I just want to comment on you know, the fact that you guys.
Well, I think you're muted.
Can you hear me now? Hello?
Not yet.
Can you hear me now?
There you go. Sorry. Yep.
Oh yeah.
Sorry about that.
So I just want to say congrats again. You know, the addition of the radioisotope onto the conjugating to the drug is such a phenomenal idea. Have you guys really followed that out, like with serial MRIs, and identified the pharmacokinetics and how long it stays there, and have you thought about doing serial dosing after it kind of dilutes out?
You know, you're talking about the basis of our R01 application, but the short answer is yes. Listen, it's an amazing opportunity. You know, I'll say it in a couple. I'll answer this in a couple ways. One is it was entirely, like I said, fortuitous that we were using an isotope, and I didn't know anything about, you know, the delivery aspect of this. But using a targeted agent like this that's radio labeled was eye-opening. So this has a half-life of just over 4 days. And we pretty much lose signal at about 7 to 9 days, you know, in most of these patients. So we image well over a week in most of these patients. And I'll say, without, you know, showing you this information, that we're seeing very positive enriched signal at our last imaging you know, time point. So routinely at 7 or 8 days, you know, we're still seeing radioisotope in our area of interest. That's very meaningful to me, because as I've worked with gadolinium as a surrogate tracer, for example, we know that clears very rapidly. And when we've done time sequencing over a period of days with gadolinium, really by the 24-hour mark, you know, 30 hours, we're not seeing much in the way of a gado signal. That means a couple of things: small molecules dispersing very quickly through the interstitium. But the other thing it means is that if we're using a targeted agent, are we getting drug engagement for as long as we can see it? I think the short answer is yes. I don't think it's an issue of just lack of clearance. I think it's really tissue engagement. It can't be confirmed without sampling, obviously, but it's a very, very encouraging signal to me that we're seeing it that far out. You raise a very important question, and I jokingly said about the research endeavor. In the ideal scenario, you're using something that you can image indefinitely, right? And you use that as a guide for redosing. Not just distribution and spatial distribution, but can you get an accurate estimation of dose? Do you know your therapeutic range, whether it be an isotope or panabinostat or anything else for that matter? And then use that as a guide for redosing. Right now, it's very haphazard. And I watch these, and I'm guilty of it, designing these clinical trials. I'm going to repeat, what, every week, every 2 weeks, every 4 weeks? It's a flip of a coin. You know, this is so different than the domain of systemic chemo, where you can monitor plasma concentrations and know where those real troughs exist. So when I say be smart as a neurosurgeon, if you're going to be involved in these, I'll stress that again: be smart. Try and capitalize on information we might garner.
And just one last question on that before we get to the panelists is, for these repeat, I know you mentioned a couple of your trials you allow retreatment. Just as a technical issue, are you using same trajectory for the brainstem and the same target, or are you on the idea that that's a higher risk approach? And they should change the target?
Yeah, thank you. We've got a limited sample. As I mentioned, 7 out of 40 some patients. We've done repeats. We've done it 3 on small occasion. We haven't seen any higher toxicity, either from the agent itself or from another trajectory, number one. We try and avoid the cannula path. Russ has published on this from the standpoint of egress of gadolinium down a biopsy tract. This cannula is degrees smaller than a biopsy needle. It's meaningfully smaller. But we do intentionally try and avoid any convergence of that path. And we're looking at that isotope egress now through previous catheter paths as a way to quantify it. And then we also capitalize in the sense that should we be applying drug into a domain that we confidently can say we didn't treat adequately the first go round. It's, excuse me, it's a phase 1 study. I don't want to get too carried away in the idea of optimizing the oncologic initiative here, but it's hard to extract that from your mind as you retreat.
Okay, great. So let's get to the panelists. I know, Dr. Storm, you have a couple meetings going on. Did you want to go first?
Sure. Yeah, again, Mark, that's great. And obviously it's always good to see neurosurgery be able to do something for this disease. But for how many of your patients have you then looked at autopsy to see how extensive, right, the disease is? And we saw the one case you showed and it had gone to the spinal cord and disseminated. When you see the patients, do you do any brain or spinal cord extraction and then look to see, even though it may look like on their MR it's pretty localized to the pons, but then you're finding it in other paraventricular regions? Is it in other lobes of the brain? Have you looked at any of that?
That's it. It's a very insightful question, Jane. Thank you. So a couple of things. Because of the time sequence, we can't really use it as a measure of drug engagement or presence of isotope or monoclonal. I can't imagine that several months or years down the road we're going to find it. I think the point of your question, however, is very insightful. So if we start to look at a population via standard treatment at autopsy, and this is fairly well known based on radiographic information, but not on autopsy insofar as I know, and I've spoken with Cynthia about this, Cynthia Hawkins. Can we start looking at patterns of relapse as a measure of regional controls we're using direct drug delivery? I think the short answer is yes. We can do this with imaging, and we can do it with pathologic tissue at the time of progression or autopsy. So it would be very, very insightful, and part of our phase 2 study is to look at patterns of relapse after treatment compared to a historical control not treated with regional therapy. How one does that, consolidating that, it's going to be a little bit of a difficult issue, but you're exactly right. Looking at patterns of relapse will be so important to know if we're making any difference regionally. It's a great question.
Dr. Storm, did you want to present your case real quick?
Sure. Are you able to see it?
Not yet.
Hold on. I thought we had it all figured out.
Mark, did you stop sharing your screen?
I did. Thank you, Michelle.
Let's see. Well, maybe if Michelle's queued up, she can go, and we'll try again once she's done.
Okay, sounds good.
All right. Can everybody see my slides?
I can see yours.
Okay.
Go in presentation mode. We can see it, but not in presentation mode.
Okay, I'll get there. Great. So I was actually going to discuss the GD2 CAR T cell approach for diffuse intrinsic pontine glioma quickly. So, as Mark just beautifully introduced, these histone mutant H3K27M positive diffuse midline gliomas really are a family of tumors that, represent one of the biggest challenges that we have in pediatric oncology widely. And they affect, of course, the pons, DIPG, the thalamus, and diffuse midline glioma of the thalamus, and the spinal cord in diffuse midline glioma affecting the cord. And as has been reviewed, this is an unfortunately common disease. The diffuse midline gliomas of the brainstem account for about half of all pediatric high-grade gliomas. This is a disease that strikes 200 to 400 children and adolescents each year in the United States. And when we account for the age at which this disease strikes, this really accounts for about 24,000 life years lost annually. So while it's a relatively rare disease, it's a very impactful one. Typically occurring around age 7 years. It's the leading cause of brain tumor-related death in children. And, unfortunately, the median survival is still only 10 months. And our ability to study these tumors had been severely limited for many decades because we just didn't have tissue resources, because this is not a tumor that can be resected, and only recently was routinely biopsied. We just didn't have any experimental model systems when I came into the field now a very long time ago. And so as a postdoctoral fellow and the new faculty, my research group established the first patient-derived cultures and mouse models of this disease, and with these resources have been able to study, cell intrinsic vulnerabilities, including, big collaborative drug screening efforts that have discovered, strategies like panobinostat, the neuroscience of this cancer and the way that it interacts in really important ways with the nervous system, the growth signals that are derived actually from both paracrine as well as electrical signaling from the normal neurons, and new immunotherapeutic approaches. And so the way that we've been able to do this has really depended largely upon early postmortem tissue donation by families and our patients. And so this is an enormous gift. We try to process everything as quickly as we can. And here's my lab at 4 a.m. working on a particular tissue donation so that we can generate these patient-derived cultures and study them to try to discover new therapies. These tissue donations often generate successful cultures, but not always. And so we actually started in an effort to try to isolate the tumor cells from the normal tissue. We looked at the cell surfaceome to try to identify what kind of antigen handles we might have for FACS sorting, with also the idea in mind that perhaps we would find something that was very highly and uniformly expressed on the tumor cells that might be a good immunotherapeutic target. And really astoundingly, over here on the right side of this heat map, we found this sugar moiety, this diacylganglioside called GD2, which is a well-known immunotherapeutic target for neuroblastoma, but was not known to be expressed in DIPG. And we find that in all of the histone mutant tumors, but not histone wild type tumors that we studied, there's very high and uniform expression of this antigen, making it actually a really great immunotherapeutic target. And so in one of the kind of best stories of serendipity of my entire career, Crystal Makel had just moved to Stanford from NIH, Crystal being someone who has pioneered CAR T-cell therapy, and her office is around the corner from mine. So I walked over with, I think, this fax plot in my hand and knocked on her door and said, you want to collaborate? So we put her CAR T-cell into our preclinical models of DIPG, and really shockingly to me, we saw tumor clearance between 1 and 2 weeks after IV CAR T-cell infusion. These tumors in the CAR T-cell treated group compared to this control CAR group just melted away. And in fact, I actually didn't believe it. I made my poor graduate student do this experiment, 5 times before I began to believe it. And we saw this in multiple different patient-derived models of DIPG, as well as spinal cord diffuse midline glioma, and in thalamic diffuse midline glioma. However, because of the location and the immunotherapy-induced tumor-associated swelling, there was a unacceptable level of toxicity in the thalamic treated group. And so what we find is that histologically, the tumors are largely cleared in preclinical models after this therapy. And there's a marked prolongation of mouse survival. However, that's only true for the mice that survive the therapy. And so the mice here that died during therapy died because of this on-tumor, on-target swelling that causes hydrocephalus and consequent herniation. And so, just thinking about inflammation in this already expanded structure, we took that as a huge note of caution in bringing this to clinical trial, and have built in multiple aspects of the clinical trial to try to address this potential tumor inflammation associated neurotoxicity. And so I'm really pleased to say that despite all COVID limitations, we were able to open this clinical trial for patients with pontine and spinal cord diffuse midline glioma, so DIPG and spinal DMG. I'm listing here all of the people at Stanford who have been working hard on this trial. It's really an enormous group, largely composed of the CAR T-cell team, together with myself and a couple of our neuro-oncologists. And so there's some exciting firsts about this. We were able to treat the very first patient with DIPG using a CAR T-cell approach. There's a second CAR T-cell trial that's just recently opened up in Seattle, targeting actually B7H3. And so there's now a couple of clinical trial options. This is the first GD2-directed CAR T-cell approach for brain tumors, and we've incorporated a step into the CAR T-cell manufacturing process to try to limit T-cell exhaustion, which is another kind of novel aspect of this trial. So a few words about the trial. We're still very early. We've treated 3 patients. I'm happy to say that we've been able to do that without dose-limiting toxicity. We've been able to manage the tumor-induced inflammation and consequences. This is for patients who are between ages 2 and 30 with disease localized to the brainstem in the case of DIPG, or to the spinal cord in case of DMG. They have to be at least 6 weeks from radiotherapy, and they can have previous chemotherapy, but there needs to be a 3-week washout period. We also need to confirm the H3K27M mutation because this GD2 sugar moiety is only upregulated in the histone mutant forms of DIPG. It's actually because the mutation dysregulates the epigenome in a way that drives the GD2 synthesis genes up. So we have to have biopsy confirmation, and the children have to have a good Lansky or Karnofsky score. So, as CAR T-cell trials go, this is a fairly involved process. There's apheresis for lymphocyte capture, and then CAR T-cell manufacturing. This takes about 3 weeks. We place an Ommaya reservoir not to deliver the cells. We're actually giving the cells IV, but to treat hydrocephalus and to monitor ICP throughout the trial. So this is a trial that can only proceed in close collaboration with our neurosurgeons here at Stanford, and Jerry Grant has been the neurosurgeon here leading that effort. Then the patients get lymphodepleting chemotherapy for 3 days in order to encourage CAR T-cell engraftment, and then get CAR T-cell infusion after 1 day of rest following that 3-day lymphodepleting chemotherapy regimen. We're giving everybody seizure prophylaxis, and we have 3 escalating dose levels. We're presently at the first dose level, 1 million cells per kilogram, and we will dose escalate, as indicated by the trial. We then monitor the patients inpatient for typically 28 days. And what we're really looking for and monitoring for and need to be able to address urgently are cytokine release syndrome, the immune effector cell acute neurotoxicity syndrome that's been observed in leukemia and lymphoma, and I think more relevant to this trial, tumor inflammation associated neurotoxicity. So the Ommaya catheter, I'll just say, allows for intracranial pressure monitoring, rapid treatment of hydrocephalus, and also gives us a window for correlative studies so that we can see if the CAR T cells are trafficking to the CNS, we can monitor cytokines, et cetera. And so with that, that incredible opportunity for correlative studies, we're measuring the CAR T cells and their trafficking, cytokines, we're doing single cell RNA-seq of the CSF, and we're looking for circulating tumor DNA. And so we'll learn a lot from this trial and hopefully be able to go not just from bench to bedside, but back bedside to bench and iterate and improve as we go forward. So many people to thank, but I want to just really highlight the patients and families whose donation of tumor tissue enabled all of this research that we do. Thanks.
Thanks so much. That's really phenomenal work. My quick question was for the animal models. I know it's always challenging with deficient and immunocompromised and immunocompetent models, and how much is it the immune response versus the actual targeting of the GD2. So were you able to tease that out? I didn't read the paper, but.
Yeah, so we use human tumor cells in an immunodeficient model, and so that certainly is a caveat of the preclinical studies. So we have the human CAR T cell, and we have the actual CAR T cell used in the trial, and the human tumor, and we felt that interaction was the one that we most wanted to test. There are murine CAR T cells, but again, then it's a different construct. It's a different T cell. And murine models of DIPG are certainly advancing. I think the in utero electroporation introduction of H3K27M together with the dominant negative P53 and constitutively active PDGFR models that have come forward in recent years are probably the best murine models. And we had planned to do that, but there's some optimization of the murine CAR T cells. So we're learning from the patients. I think there's enough evidence from the in vivo studies to move forward, but there's so many interpatient variables and just differences in the human immune system compared to the mouse immune system. So we are definitely learning.
Thank you so much. That was phenomenal. Dr. Storm, Dr. Hakerson, when you guys want to go to your case?
Sure, whatever works best for Jay. He looks busier than me.
I will try to share my screen again.
There you go. Show us the password, though.
We don't see your talk. We just see your. I think you just chose the wrong window. You see your iTunes.
Oh my God.
You unshare and then share with the actual PowerPoint.
Try that again. I just switched it. Did it work?
There you go. Yep.
All right. I'm trainable, despite what they told me when I was an intern, I guess. But so yeah, obviously, the work Michelle's doing is unbelievable, and as you'll see here, we're trying to bring her in to help us with collaborations. And so, this is it's just an oncoplot down the bottom right from PNOC 003, which is sort of a feasibility and for biopsy, whole genome, and some RNA-seq. And you see, right, the K27 mutation, P53, ATRX, kind of the usual suspects, but a lot of other variations here, in which even though there's some commonalities there, I think that this is obviously a unique disease to each person, and I think we saw some of that with Mark's work and some of the outcomes. And so, one of the things that we wanted to do is start looking at multi-omics for DIPG, and this came out of work that we did with CPTAC and really craniopharyngiomas, and it was a huge effort as part of the CPTAC CBTN group with multiple authors. These are just a handful. It's coming out in a Cell paper in the next few weeks, and what we did was looked at a bunch of different groups of pediatric tumors. And what we saw and weren't expecting was this clustering of craniopharyngiomas and low-grade gliomas that have a V to E mutation when you start layering on whole genome, RNA-seq, proteomics, and phosphoproteomics. And so this is just a proteomic heat map showing that at the protein level, right, even though we wouldn't have predicted it at the genomic level or the expression level, which you can see over here, but the adamantinomatous craniopharyngiomas were completely clustering with the low-grade V600E mutations. And then when we looked at the phosphoproteomics, we were seeing an upregulation through MAP kinase pathway as well, which through a V to E upregulation, you wouldn't be surprised in the low-grade glioma. But as we were seeing that there, and this actually corroborates some really nice, elegant work that Todd has done, kind of looking at this and seeing opportunities when you do this layering of multi-omics to not only reduce the signal to noise, but then start looking for targets that you're seeing that you probably never otherwise would have looked at. And so that's what we started doing, expanding to DIPG, other diffuse midline gliomas, as well as just other pediatric high-grade gliomas. And so this is actually a plot from the Open PBTA project, starting to bring in all these different tumors. And when we already start seeing some clustering in these. Again, I mentioned Michelle. We're partnering with a group up at Dana-Farber and also Michelle's group out in Stanford, looking at single cell and single nuke analysis to again start layering all this together. And are there actually targets that we wouldn't have otherwise predicted at the genomic level? And so this is part of the Open PBTA project. This is Casey Green from HUP. He's over at Penn. He's kind of a kindred spirit in terms of open science, collaborating. He's actually written papers, completely open science, review paper. It's online. Anyone who contributes to the manuscript gets added as an author, and then you just keep track in a very kind of Wikipedia fashion. And so this, for the Open PBTA, which is where that graph came from, is all from GitHub. And so if you go on to this website, these are all the people that have, some of the people that have gone on there to look at, and here they're called branches, but basically just pipelines. So it has access to our cloud, our pediatric cloud, Cavatica, which we put all the whole genome, RNA-seq, and proteomics. And then anyone can bring their pipelines into it, look at the ones that we have up there, bring their own. You can work independently, and then if enough of the community starts saying that this looks like an important pipeline to run analyses with, then that can actually be brought into the master branch. And this is where, like I said, the other data has been generated. And I think that in these open science, collaborative ways, working with so many of the even people on this call, I think it's exciting to start finding this multi-omic that we're doing, but also these multi-therapies. Can we find small molecules that Mark can now use with enhanced delivery, looking at CAR-T and immunotherapy? I think just like we learn more through these multi-omic analyses, these multimodality treatments are the way that we're going to get on top of this disease and start learning more and more about the multiple subtypes that are inevitably going to result. And so this is our team on the left, and these are our patients who we do this for on the right. So with that, I'll turn it over to Todd or any questions. And thanks for including me.
Thanks so much. I mean, that's really phenomenal collaborative work. I agree with you that it's, even though we're finding these unique mutations, it's likely it's going to turn out to be more like a multi-mutations in so many different patients. And until we start gathering thousands of tissue samples, we're not going to realize that, which is, I think, where eventually we'll get to. But this is speeding it up, and that's a phenomenal project that you have. So thank you for sharing that. Hopefully we could all take a part with that. Todd?
Yeah, let me just share. So I basically just have a case or two that I kind of wanted to throw up just as really a platform to sort of ask questions more than anything else, questions of, of Jay, Michelle, and Mark, and other people who are involved. So I'll just kind of throw out this one case. And the principle is looking at sort of atypical intrinsic diffuse tumors and how we may have to handle those, or just asking how people handle them, especially in the context of drug delivery. So this is a recent patient we saw who's 20, has headaches, extremity weakness, had some vertigo, had a needle biopsy that was negative, and then was referred over for treatment. And this is what his scan looks like. So the tensor imaging is not that useful, but you can see that he's got a tumor that has a lot of features that would be consistent with sort of your standard pontine DMG, but it's located, more caudally in the medulla. He's an older kid. His symptom pattern is, similar, although it was somewhat prolonged, is more of a few months. When you look at the axial imaging, it kind of looks like this, and you can see the previous biopsy tract, which looks like it may have just been kind of a little high on the edge. And sort of the question that I had for Mark, and also I'd be interested to know kind of what Michelle thinks too, is just how would you think about approaching a tumor like this? Both, like we can talk about the diagnostic piece since this is a surgical group. Would you rebiopsy it? If so, how would you do it? Is it necessary? And then from the standpoint of drug delivery, is the fact that it's not actually pontine, how much does that impact what we know about what we can do in terms of direct delivery of therapies and things like that? And so I don't know, Mark, sort of what your perspective would be on what to do with this patient.
So thanks, Michael. I mean, the first thing is, as you pointed out, I wouldn't throw this into the standard rubric of DIPG. DMG maybe, but certainly with this epicenter being outside the ponds, even if the person's presenting symptoms, the age range, this in my mind does not qualify as typical in any way, shape, or form. So I'd strongly advocate biopsy in a situation like this. The fact that he had an attempted biopsy that was non-diagnostic, does that justify another approach? I think so. This guy clearly has symptoms. His presentation with headaches is also very interesting since there's no hydro. Is there some other element that's not neoplastic that's affecting this? Rhomboencephalitis, et cetera. I think collecting CSF, given what's been known from the standpoint of the potential of getting cell-free DNA and the DIPG and DMG population with pretty good proficiency, is not a bad diagnostic attempt right here. And that might be what I would start with in doing whole exome sequencing in that. So, and those would be my initial thoughts about this. I certainly would want tissue. I'd start with cell-free DNA, but I think this is certainly not consistent with the very typical DIPG.
Yeah, I agree. I would be strongly requesting biopsy from our neurosurgeons. I think you need tissue here.
Yeah. I mean, Jay, you think so too, I imagine, in Toba?
Yeah, I would definitely get tissue.
Yeah, absolutely. I agree here.
Yeah, that's what we thought too. So, I mean, what we did is just an open biopsy, and we actually got CSF, Mark, and also, but just did an open biopsy dorsally where it came to the surface. And so we're still waiting for the path, but I just thought it was interesting to think about it in the context of these kind of non-typical type of presentations. And I don't know what his, what his biology is going to demonstrate ultimately, but let's just say that it did show an H3K27M, then, how would you just be approaching this with sort of your standard upfront radiation, or based on the location of it, would you think about a trial straight up right off the bat, or kind of what would your guys' thought processes be?
I would go to radiation. I would treat it like a DIPG.
I agree 100%.
And one thing that just kind of, I think, shows a little bit of my ignorance is how much talk is there, or is there any, between proton and photon radiation in the context of DIPG? Is that a subject at all?
There's not as much discussion of it because, I think there's less sort of concern in the brainstem, for protecting it. You typically don't hit supratentorial tissue with that radiation, if it's traditional photon radiation. And so there's less concern for long-term cognitive outcome, and, less concern for hitting other structures. Like in the cord, you would worry about getting the conformational radiation fields to avoid the heart, et cetera. But in this location, there's just less discussion of it. Mark, do you have anything to?
No, I would agree with that. I mean, I've never seen the benefit here, honestly. The one other thing this is just really commentary, Michael, that for any of us that see a large volume of these individuals quite desperate, looking for treatment alternatives, do come mislabeled, just based on clinical assessment. It's always a good news story when you get a patient, that potentially has a low-grade cervicomedullary tumor or a focal tumor. This happens with some regularity, and I think that any of us on the line today at high-volume centers, aren't guilty of that. But these patients, by and large, are shuttled into a domain of really just tragic outcomes. But I think they search rightfully for alternatives. And frequently you will see a different pathophysiology and or a different pathology. So I just stress the need that one needs to be careful about the intake of information and what we're telling these patients.
Yeah, that's great. Thanks, guys. I don't know, Toba, did you have something where you want me to? I can shut this down.
Todd, how did you do the biopsy there? How did you approach it? How did the patient do? How did it go?
He did fine. So I mean, we just did it. So we just did a sub-occip and just approached it directly, almost like it was like an exophytic tumor, and just did a small biopsy. Took CSF on the way in. Obviously, we mapped out the floor was fourth ventricle with monitoring because it wasn't really obvious anatomically. Where the safest entry site was going to be. So we kind of used established landmarks above the obex in the midline and mapped it out, and then went in there. And he's doing fine neurologically. The monitoring was pretty quiet. There was a little bit of a drop of his lower extremity SSCPs on his more affected side, but everything else was quiet. And so we're still waiting for the path results.
So a posterior midline approach is kind of what you took then.
Yep.
Okay.
Exactly. Yeah, I mean, we talked to the family lab about doing another needle biopsy too, and just felt like, look, he's already been through that once, and getting another negative biopsy would be pretty discouraging.
Yeah, no, for sure.
Hey, Michael, can I ask a question really to, I guess, Jay or Michelle? Now, how far away are we from doing an LP versus a stereotactic needle biopsy to establish diagnosis? Of course, there's information if it's a targeted sequencing array that you're not going to get, but should we be thinking about that now, or is it too early as upfront diagnostic sampling?
I mean, at least what we've been doing with all our liquid biopsies, I'd say it's a little bit early. I mean, we're trying to get started with high frequency ultrasound with these to then do even just blood draws and then potentially CSF as well to see can we increase the yield. But at least that's an experience in our center, but I don't know what Michelle's is.
Yeah, I agree. I think it's early. I think we're still optimizing the ctDNA, tests. We don't have a CLIA certified test. I think they're not as sensitive, certainly as biopsy. So I think we still have a ways to go.
Okay, great. Thank you, Todd. Toba, do you want to share your case?
Sure. I think thank you for the great talks, both from Dr. Manji and Dr. Swedane. I think one of the things that I wanted to talk about here is the ONC201 trial that we have going on here, and a patient that we enrolled in that trial, as well as how we manage these kids who are really found incidentally. So let me share my screen here. Can you see my screen?
Yeah, if you just go to presentation mode.
Yep. Okay,
Perfect.
so this is a 2-year-old who presented to his neurologist, his primary care doctor, and then his neurologist, mainly for this left hand clenching. That mom just noticed he was clenching his left hand. It's really a non-specific finding. And this MRI was done in December of 2018. And it was found to have this lesion. There were some concerns we had at that point. Other than this finding, there's really no other finding in this kid. There's no long tract signs, nothing else to be indicative of any sort of problem going on. He also had an EEG that didn't show anything that was that would be indicative of that left hand clenching either. So we had a long discussion with the family, and they opted to, we told them we were concerned with this finding and that we would watch it. We proceeded to get imaging every 3 months thereafter. We fast forward to 10/2019, and you see this finding. And I guess the question I'd love to pose to everybody here on the panel, as well as Dr. Swedane, is, at what point would you consider treatment of these kids now that we're getting an MRIs on a lot of kids? At this point in 10/2019, this child was still asymptomatic, so which is surprising, but completely asymptomatic, no hydrocephalus. I can tell you what we did, and I'd love to get your opinion. So family was did not want to consider any sort of biopsy because of the risks, etc. We actually did send a liquid biopsy, and that was positive for the H3K27M. But again, this is all experimental. We then proceeded ahead to give radiation. This is him. He started radiation on November of 2019 and finished in January of 2020, and then was started on ONC201 concurrently. And so this is here in July of 2020. This is now in October of 2020. And now he's had some slight progression. So he's actually doing very well, really not symptomatic. The only thing is maybe a little bit of loss of gag reflex. So love to get your opinion on how you would manage these children who show up with these incidental findings and then progress.
So this is a really fascinating case, and I think I actually know this patient as well.
Yes, you do.
Yeah. So I think one point I'd like to make is that in experimental model systems where the tumor is, where it's a murine genetic model, the mutation needs to be introduced prenatally in order for tumors to develop. And this is consistent with, other cancers in which we know that, for example, in childhood leukemia, the main oncogenic mutations often happen prenatally and can be found in blood spots. And I think the question is that, developmentally, when does the H3K27M mutation happen in a susceptible cell of origin, probably a precursor cell? When does the somatic mutation happen, and does it actually have to happen prenatally? And I think we don't know as a field the answer, but there's a possibility that kids with DIPG, if we were to have scanned them at some point in childhood, we would find some subtle signal abnormality, right? And I know lots of examples of this where we find them incidentally and a tumor, becomes symptomatic later, as well as kids who had pretty normal looking scans, but maybe in retrospect there was something fuzzy and funny about them. So I think, it's just a very interesting basic question about the disease. In terms of management, I think I would have done exactly what you did. I would have monitored it. And when it began to grow, I think that's when I would treat it, because we know that these tumors do have a propensity to spread, that in 75% of cases at autopsy, they've spread very far and wide in the nervous system. And so I think I would probably want to do radiation a little bit earlier, once there was clear evidence that it was progressing and growing. And I think that's exactly what you guys did. So that's exactly how I would handle it.
Great, thank you. Any other recommendations or things that you guys would do differently?
We had one very similar to that, and we did exactly that. We watched her, and the minute it started to grow, we just sent her for radiation.
And is everybody biopsying all of these, or what's the general rule for everybody?
At CHOP, we offer everybody a biopsy. Not every family does, and we don't, pressure them, but we will offer it to every DIPG patient.
Yeah, that's how we are too. We offer it to everybody, but they don't all go ahead with it.
I'm always the bad guy. It's a minority that we ever biopsy. It's not written into most of our study entries. I know for ONC201, yes. It sounds like for the CAR T cell, yes. When there's a mandate for study entry, it makes perfect sense. When there's some variability with regard to presentation, without hesitation. So like I said, I probably stand in the minority still. Maybe my age, I don't know.
Okay, I'll stop sharing now.
But for the convection enhanced delivery, Dr. Sinane, all those patients are symptomatic, or are those patients who are documented growth, or when do you kind of pull the trigger for treatment in that trial?
It's a good question. You were showing those films, Tova. I was salivating, waiting to treat a tumor with that small of a volume. It's easily encompassed by a drug. That's not hard to really reach that. It's not disseminated yet. Without having a proven track record of clinical benefit, it's hard to justify it. So I would have done exactly the same. But could you catch these earlier? And there's no question they're more manageable if you can use a regional drug delivery platform. Insofar as the study that we've been conducting in the phase 1 or the phase 2 study that we're hoping to activate this year, it's every patient is symptomatic because they present in a conventional way, and it's after radiation therapy. We had a lot of problems with regulatory designing the trial as far as an interface which was unproven immediately after radiation therapy, given that majority of the kids are asymptomatic and they're kind of on their quote unquote tumor holiday. So why invoke something that's experimental? But from the standpoint of tolerance, tumor volume, infusion volume, tumor volume, targeting from a distribution issue, it makes all the sense in the world to do it while it's as small as you can potentially get at it. So there's a fairly finite window that we use, and that's 4 weeks after completion radiation therapy at minimum and no greater than 14 weeks. We've submitted an amendment to go up to 16 weeks, but one of the other reasons we did that, Michael, is because a lot of these tumors progress at such a rapid rate. On a phase 1 study, we thought it'd be very difficult to parse out and attribute disease progression from toxicity of agent that we're administering, whether it be delayed or acute. So it's already hard to parse out this difference of tumor progression versus treatment-related effects. So we try and keep that as finite as we can, not to contaminate the attribution of a clinical worsening.
Great. Okay, any other final comments? Otherwise, I know it's already getting pretty late. I don't want to take anybody's time, but I just wanted to say that was phenomenal talks by everybody, and it's great to see so much collaboration going on for this difficult disease. So thank you all for your time and talking tonight.
Okay. Thanks.
Be a part. Thank you.
See
Okay,
you.
take care.
Bye.
Everybody be safe.
Later, Prop Diesel.